Hi everyone, welcome back to the channel. Today we're diving into one of the most important trauma topics, facial bone fractures. Clinically, we divide the face into upper face, which include frontal bone and frontal sinus. Midface, which include nasal bones, maxilla, zygoma, orbit. And lower face, include mandible and TMJ. Primary survey concerns. A. Check for airway. Any facial swelling, bleeding, midface instability, or a fractured mandible can compromise the airway. If the patient is deteriorating, secure early intubation. B. Check the breathing as high-energy trauma may involve the chest too. C. For circulation. Facial bleeding looks dramatic but rarely causes shock. Use pressure and packing to control any bleeding. D. Check the disability. Check vision, pupils, and watch for orbital compartment syndrome. And E. For exposure. Look carefully for deformity, asymmetry, lacerations, avulsed teeth, or CSF leak. The general clinical signs include pain, swelling, bruising, facial asymmetry, step deformity on palpation, crepitus, malocclusion, epistaxis, and infraorbital numbness, which is very common in zygomatic and orbital floor fractures. Nasal bone fracture is the most common facial fracture. Key features are epistaxis, tenderness and crepitus, visible deformity, and most important, septal hematoma. A septal hematoma looks like a bulging, soft swelling on the nasal septum. It must be drained immediately to prevent cartilage necrosis and a saddle nose deformity. Management of nasal bone fracture is ice and analgesia. Drain any septal hematoma, closed reduction after swelling subsides, which is usually 7 to 14 days. And will need an ENT follow-up. Second, zygomaticomaxillary complex, also known as tripod fracture. This involves 3 points, the zygomatic arch, the orbital rim, and the maxillary sinus wall. Features of tripod fracture include flattened cheek or loss of malar prominence. Trismus from coronoid impingement, infraorbital nerve numbness, step deformity at infraorbital rim, and diplopia if the orbit is involved. Its management are CT facial bones. If displaced, then surgical fixation. If non-displaced, then conservative treatment. Third, orbital floor or blowout fracture. This is caused by sudden increase in intraorbital pressure, which forces the orbital contents into the maxillary sinus. Features are diplopia, especially on upward gaze, enophthalmos, infraorbital numbness, orbital emphysema, and limited upward gaze from inferior rectus entrapment. Emergency red flags such as orbital compartment syndrome should be suspected in decreased vision, pain, proptosis, and a tight globe. This requires an urgent lateral canthotomy. Management of orbital floor fracture. Avoid nose blowing, oral antibiotics if sinus involved, ophthalmology referral, and surgical repair for persistent diplopia or significant enophthalmos. Fourth, Lefort fractures. These are classic midface fractures. Lefort 1, floating palate. Horizontal fracture above the teeth, causing mobility of the upper dental arch. Lefort 2, floating maxilla. Pyramidal fracture and infraorbital numbness is common. Lefort 3, floating face. Craniofacial dissociation and separation of the midface from the skull base. Features of Lefort fractures include facial mobility when rocking the maxilla, massive swelling, malocclusion, CSF rhinorrhea, and high risk of airway compromise. Management include protect airway, CT facial and CT brain. ENT, max fax, or neurosurgery referral. Surgical fixation. And consider antibiotics if open fracture or CSF leak depending on hospital protocol. Fifth, mandibular fracture. The mandible is a ring, so fractures usually occur in 2 places. Common sites are condyle, angle, body, parasymphysis. Features are malocclusion, trismus, pain and swelling, step deformity, lower lip numbness, tooth fractures or avulsions. Management include analgesia, soft diet, antibiotics for open fractures, and maxillofacial referral for fixation. Lastly, frontal bone and frontal sinus fractures. These are high-energy injuries often associated with intracranial trauma. Patients might have forehead depression, lacerations over the sinus, CSF rhinorrhea, severe headache, and associated brain injury. Management are CT brain and CT facial, neurosurgical involvement. And posterior table fracture or CSF leak often requires surgery. Major complications of facial bone fractures are airway obstruction, cosmetic deformity, malocclusion, enophthalmos, vision loss, CSF leak causing meningitis, non-union or malunion, dental loss, infraorbital or mental nerve paresthesia. To summarize your ED priorities: protect the airway, control bleeding, clear the cervical spine, order CT imaging, Drain any septal hematoma. Recognize orbital compartment syndrome early. Avoid nose blowing in orbital or sinus fractures. Give antibiotics for open fractures or sinus involvement. Refer MAX/FAX, ENT, ophthalmology or neurosurgery early. These are some quick mnemonics. Lefort fractures for floating palate, maxilla, and face. Blowout fracture signs like diplopia, infraorbital numbness, and enophthalmos. And mental nerve causing lower lip numbness and mandibular fracture. That's all for this video. Thank you.